This series of slides is going to describe the hip joint and the client assessment of the hip joint. We've already gone through how to subjectively assess, in theory, an area of the body, and we're now going to focus on the hip joint subjective assessment. Some of the aims of the subjective assessment, particularly related to the hip joint, are to gain a good rapport with the client, to understand the main problem, whether it is one of pain in the hip or stiffness around the area, to determine if there are any red or yellow flags, red flags indicating serious pathology and yellow flags indicating a biopsychosocial issue. And finally, to set the standard for the objective assessment. So, if we move on to the subjective assessment of the hip, initially, as you remember from before, the most important thing is to collect the client details. For example, date of birth, name, address, date of birth, and contact details. The next thing to move on to is the pain chart or the body chart. You most commonly see in hip pathologies that the patient will describe a gripping of the upper thigh and a pain of a deep aching quality. Sometimes hip pathologies may refer into the groin, into the lateral aspect of the thigh and inner thigh, or even down as far as the knee. And occasionally patients may complain of knee pain, which is actually referred from the hip joint itself. The next thing to collect is some of the aggravating and easing factors. And aggravating factors often may be weight bearing, such as walking or prolonged standing. And it is useful at this point to find out exactly how long it takes for their pathology or pain to come on, whether it's pain or stiffness. Get a time scale, understand how long it takes to come on, and then also how long it takes to ease off after the aggravating factor has been reduced. It's also useful to know what eases the hip joint pain or hip pain, and this will be a way of potentially easing the pain if you've aggravated it during an assessment. Next, the 24-hour pattern is a useful one to find out about how their pain relates to night and then through the day, in terms of, does it get worse, does it get better, does their pain increase towards the end of the day, which might indicate a sort of arthritic type pathology. Is it worse in the mornings but then eases off, which might indicate something more inflammatory. So it is useful to find out the 24-hour pattern and determine potentially some of the pathologies which might be occurring within the joint area. The past medical history is, as explained in the previous subjective assessment slides, as is the social history and drug history. And any special questions should always be determined to exclude serious pathologies or red flags. It's useful at this point to consider that potentially there may be some differential diagnosis involved. And this may be, for example, anything intra-abdominal, such as appendicitis or intrapelvic disease. It may be something referred into that area, such as a femoral hernia, or indeed from the spine or SIJ, particularly spinal root L3 will send information to the hip. At this point, it's useful to consider some of the kinematics of the joint, of the hip joint, which are useful to know when considering your assessment of the hip joint. So we're going to now move on to the objective area and just briefly look at the anatomy and joint kinematics. So the anatomy of the hip joint has been covered elsewhere, so I won't dwell on that for this slide. But just to consider briefly about the joint kinematics. When standing, if you look at the slide and the picture on the right-hand side of the slide of the man standing, and you will see that most of the time people should stand with their weight evenly distributed between two legs. But occasionally you can get people who may have leg length difference, as shown in the picture here, with shortening and tensioning of different muscles throughout the area. Some people may habitually stand on one leg or have a different weight distribution. So this is first thing is worth considering. It's also worth thinking about their gait and how they walk. And this will be considered towards the end of the objective assessment. And finally, for this slide, it's now useful to go on and think further about some structural or skeletal changes which may occur within the hip joint and cause problems or pathologies. This is called anteversion and retroversion, or coxa valga and vera. These structural changes of anteversion and retroversion are best explained with the diagram on the right. On the top diagram, you will see a diagram where the angle of the neck of the femur relative to the horizontal shows an angle of 15 degrees. And this is normal, and the position of the normal hip joint is in relative anteversion. So there's a 15-degree angle normally relative to the end of the femur. But in some cases, there may be a structural change whereby the anteversion becomes excessive up to angles of 35 degrees. And in these children, in these people, you will commonly see symptoms where children will sit in a W position or pigeon-toed or appear to have excessive medial rotation of the hip. They won't like sitting cross-legged and will find that generally uncomfortable. The opposite to excessive anteversion is retroversion. And this is where that angle, the normal angle of anteversion, is reduced to 5 degrees. And this may be seen clinically as a Charlie Chaplin style gait with wide reaching feet, or they may indeed get groin pain if they try to turn their hips inwards, such as sitting cross-legged on a chair. The way of assessing both anteversion and retroversion is through a test called Craig's test, which will be covered later. The other potential structural changes at the hip is coxa valga or coxa vera, which has an effect on the abductors which insert around the area of the greater trochanter of the hip. And this is, as you can see from the diagram on the right-hand side, is the angle of inclination, where normal is 125, coxa vera is 105, and coxa valga is 140. If we now move on to the objective assessment, we always begin any objective assessment with observation. So initially observe your client. Look at the way that they habitually stand and check for potential changes in muscle tone, skin symmetry marks, and muscle wasting, any scars that may be visible, etc. Next thing is to look for levels and symmetry, deformities and compensations. And this is important to look from behind, in front and from both sides. It's also useful to get an idea of if there is any leg length difference, and this can be assessed through looking at the iliac crests and the levels of the greater trochanter. Finally, it may be useful at this stage to assess their postural style by looking at the line of gravity through the hip. If you look at the ASIS as well, relative to the PSIS, there should be a 5 to 12 degree line in terms of anterior and posterior tilt. After observation, it is useful to then move on to a functional test, and this is useful and may stem from your aggravating factor. It may be used to assess the quality, the ability, and the range within a movement. Always assess when the pain starts in the activity and be aware of what the hip is doing at that point. Some examples of functional tests may be one-legged standing, a sit to stand or stand to sit, going up and down stairs, tying a shoelace, getting onto a bike, or just walking. Finally, for this section, we will consider gait. Gait is walking style, and with hip pathologies, you may see various types of gait styles. Some of the more common ones will be a gait style where people spend less time on the pathological side. They may be demonstrating a Trendelenburg gait, and Trendelenburg is something that we'll consider later. Waddling gait, where there's bilateral weakness of the abductors. A swinging gait, which may indicate a arthrodesis or fusion of the hip joint, and an adductor gait where there's increased spasm in the adductors.